Good morning. At the outset, I'd like to thank the college for inviting me to do this talk today. So in this talk, I'll be discussing the role of anterior segment imaging in relation to glaucoma. As you know, evaluation of the drainage angle is critical for accurate diagnosis and appropriate therapeutic intervention. And one needs to remember that there's a wide spectrum of anatomical variation in the drainage angle in normal and affected eyes. I'll be discussing the potential benefits and limitations of the anterior segment OCT when compared with conventional gonioscopy and ultrasound biomicroscopy. The forces at different anatomic levels in the eye may be responsible for the pathogenesis of angle closure glaucoma. Some are pulling mechanisms and some are pushing mechanisms. Therefore, assessing the anterior chamber angle anatomy and surrounding structures with anterior segment imaging is of tremendous importance for identifying individuals at an early stage of angle closure and guiding therapeutic interventions. One needs to remember that gonioscopy remains the reference standard for assessing the anterior chamber angle. It permits dynamic visualization of the entire angle quadrant. I will highlight few important points about gonioscopy, as this is the simplest technique to visualize the angle. With this, we visualize the opposite angle. What we see is a mirror image and not an inverted image. If we see superior angle, it is a superior angle, not the inferior angle that we see. So it's a mirror image and not an inverted image. These are the different types of gonio lenses available in our clinics. Gonioscopy should be performed in a relatively dark room using a shorter, less bright slit beam of about 2 to 3 millimeters under topical anesthesia. An eye should be examined in the primary position. One needs to maintain only a light pressure on the lens, as too much pressure will expand the angle. First, better to examine the inferior angle, as this is the widest. So this is an open angle. We can see all the structures in the angle, starting from the Sholby's line to ciliary body band. And this is a closed angle where we are not able to see any of the above structures. So gonioscopy allows us to do indentation to differentiate appositional and synachial angle closure, which is actually an advantage over other imaging modalities. But it has drawbacks. A proper training is required to assess the angle, and it is a contact technique which can be cumbersome to the patient. Also, it's a subjective technique which can be affected by so many factors. In addition, it does not provide quantitative evaluation of the angle, and it has limited value in visualizing structures posterior to the iris. So on the other hand, imaging of the anterior segment offers an objective method for visualizing the angle and adjacent anatomical structures. It permits both qualitative as well as quantitative analysis, which can be used to monitor progression over time. And there are so many methods available to image the anterior chamber angle, and these are some of it: ultrasound biomicroscopy, shim flow photography, ICAM, and the anterior segment OCT. So ultrasound biomicroscopy, or UBM, is a high-frequency ultrasound machine. However, UBM is relatively more uncomfortable, and it requires a supine position and a highly skilled operator in order to obtain good quality images. It requires a cup with a coupling medium or a probe, but its major advantage lies in its ability to detect structures posterior to the iris. Therefore, we can get an idea about secondary angle closure mechanisms such as plateau iris, ciliary effusions, or iridociliary masses. Shim-flu photography is a pentacam which uses a rotating Shim-flu camera to provide a three-dimensional image of the anterior segment. Although this non-contact device allows rapid image acquisition and provides measurements of anterior chamber depth and volume, corneal thickness and lens thickness, it does not provide detailed information about the angle recess due to light scattering. Therefore, it has limited application in documenting angle closure. iCam is another way to image anterior chamber angle. The iCam was originally designed to obtain wide field photographs of the retina in pediatric cases. However, the modified optical technique can be used to assess the anterior chamber angle, and they have shown a good agreement between the iCam and gonioscopy findings. So anterior segment OCT is what is being used frequently to image the anterior segment. It's a high-resolution cross-sectional imaging modality first described in 1994 using the same wavelength of light as retinal OCT, which is 830 nanometers. Imaging of the anterior segment with a longer wavelength of 1310 millimeters was developed later. Anterior segment OCT uses the principle of low coherence interferometry instead of ultrasound to produce high resolution images. So ASOCT technique measures the delay and the intensity of the light reflected from a reference mirror, reflected from the tissue structure being analyzed, and compares it with a light reflected from a reference mirror. And the signal intensity depends on the optical properties of the tissues. And then the device uses these signals to construct a sagittal cross-sectional image of the structure being analyzed. So when we compare the ASOCT with the UBM, UBM has the unique advantage of enabling visualization of structures posterior to the iris, such as ciliary body, zonules, and peripheral lens. ASOCT has a longer scan length compared to the UBM, and it is a non-contact technique which is comfortable for the patient. So ASOCT can be used as an adjunct to gonioscopy as well as a substitute when gonioscopy is not feasible, either due to corneal scarring or following corneal grafts, or when there's lack of patient cooperation. It is an extremely useful tool as a patient education tool, especially when laser peripheral iridotomy is being recommended. And this is a pre-laser OCT, one on the left, and one on the right is a post-laser OCT of the same patient. Being a non-contact and can be performed under dark conditions, it allows us to assess the angle during physiological mydriasis. In these two images, you can see how the angle parameters differ in physiological mydriasis. In the first image, the angle is narrow as the pupil is dilated, whereas in the second image, the angle opens up when the pupil is constricted in bright light. So as it gives a full anterior chamber view, we are able to assess the corneal thickness, then anterior chamber depth, the lens vault, and angle-to-angle distance, which are important in guiding therapeutic decisions in angle closure. An important landmark to identify when interpreting ASOCT images is the scleral spur. This is visible as an inward projection of the sclera at the junction between the inner scleral and the corneal curvatures. Scleral spur location is reported to be successful in about 72% of the images obtained with anterior segment OCT. And we can also visualize the Schlemm's canal and Scholby's line. And the trabecular meshwork lies between the Schlemm's canal and, the Scholby's line and the scleral spur. Anterior segment OCT plays an important role not only in identifying the angle structures qualitatively, but also it provides quantitative measurements by using special software. So OCT goniometry is the new term given for these objective measurement tools. The commonly used quantitative parameters include Angle opening distance at 500 millimeters, that is AOD 500, then at 750 micrometers, AOD 750, trabecular space area, and the scleral spur angle. A wide angle-to-angle scan of about 15.5 millimeters allows us dual angle assessment, and this enables us to measure the lens vault. Lens vault is the height of the lens above the line drawn from one scleral spur to the other. So, study by Ting Ong demonstrated that angle closure patients had a mean lens vault of about 901 micrometers compared to 316 micrometers for controls. Also, they demonstrated that an increased lens vault increases the risk of angle closure by 48 times compared with a smaller vault. So, there are new insights from imaging to assess the risk of development of primary angle closure. The risk factors include increased iris thickness and area, reduced anterior chamber width and the depth, reduced anterior chamber area and the volume, and steeper lens vault. So, higher the risk of angle closure with a steeper lens vault and a shorter anterior chamber width. So, in majority of the patients with narrow angles, angles open up following peripheral iridotomy. We can see that on gonioscopy as well as on ASOCT. But in certain patients, it does not happen like that. So, this is a patient who has had a patent iridotomy, but still the angle is closed. If you take a look at the parameters of the ASOCT, you can see that the patient has a high lens vault. So, to relieve the crowding of the angle, this patient needs to undergo a lens removal. So, this is the ASOCT of a patient presented with high IOP. What can you see? We can see a deep anterior chamber and a closed angle. So, and this is the UBM of the same patient. There is anterior rotation of the ciliary body. So, this is plateau iris syndrome. So, first image is of a pre-blinking in an eye with pigment dispersion syndrome, and second image is of post-blinking, which shows increased iris concavity and lenticular the iris pigment lenticular contact. So, ASOCT can be used to assess the contour, iris contour in pigment dispersion syndrome. And this condition, the pigment liberation, is secondary to rubbing between the iris pigment epithelium and the lens sonules. An ASOCT is a very useful tool in patients following trauma, particularly in the presence of hyphema, to assess the amount of damage. Here, that patient has angle recession and choroidal hemorrhage. This is another patient who has had a patent iridotomy and iridoplasty. But still the angle is closed, and this concavity is from iridoplasty, which is too central to be effective. And this patient has a significant cataract as well. So, patients with narrow angles with significant cataract or high lens vault needs lens removal rather than laser treatment. So, we can see how the angle has opened up in these pre and post-op OCT images following lens removal. And ASOCT can be used to evaluate the filtering blebs or glaucoma drainage devices in the postoperative period. So, clinically, blebs can be described as diffuse, cystic, encapsulated or flat. However, these descriptions are subjective. So, therefore, visualizing intra-bleb morphology with anterior segment OCT may enhance our understanding about the bleb. So, first image shows a functioning bleb, and second image shows a non-functioning flat bleb, and the third image shows a patent drainage device. And this can also be used to assess the cornea. I'm not going to go into details, right? But there are limitations as well. Structures behind the iris cannot be visualized with anterior segment OCT, hence diagnosis of posterior mechanisms of angle closure is difficult. Also, there's a cost involved, unlike gonioscopy. Recently, there has been increasing interest in assessing dynamic factors such as changes in the iris volume and contour that may identify eyes that are at risk of acute primary angle closure. So in a summary, angle assessment is essential for glaucoma management, and gonioscopy remains the reference standard, and ASOCT can be used as an adjunct or as a substitute when gonioscopy is not feasible. And the important landmarks to identify in ASOCT include scleral spur angle, the lens vault, anterior chamber depth, and the AC width. And thank you.